Today, we are joined by Paula Pickard. Paula is a registered nurse with over 36 years of healthcare experience, which includes working in various clinical settings across the care continuum. Paula has worked at Horizon Health Network, the Mural Program, Victoria Order of Nurses, the University of New Brunswick Nursing Faculty, as well as the Ottawa Heart Institute and the Ottawa Civic Hospital. Over the past 13 years, Paula has been involved in quality improvement roles within Horizon, such as being a patient safety consultant, and currently she is the regional manager of chronic disease within the primary healthcare program. Paula maintains certifications with LEADS from the Canadian College of Health Leaders, the Canadian Patient Safety Officer, Horizon Cornerstone Leadership, Horizon Lean Six Sigma White Belt, and recently she attained her TCPS2 core certification. Today, Paula will be speaking with us about the research projects she has been participating in with Horizon's clinical teams and the lessons learned in a community setting from a novice researcher perspective. Thank you for joining us today, Paula. The floor is yours, and please take it away.
Thank you very much for that warm welcome. Good afternoon, everyone. So, as introduced, my topic is titled Using Research to Help Improve Community Clinical Care and Outcomes. So, I am speaking today on behalf as a novice researcher. So, that's my perspective today. And my agenda, I'm going to give just a brief overview of the why I got involved in research, and then to provide some highlights on the two studies that I'm involved in. The one titled My Wellness Plan, and the second one, CAPS, Coordinated Aging in Place Services. And then finally, just to review reflections that I've learned along the way on this journey. So the why for research. So why did I get involved in research? So like I said, I am a novice researcher. I am a registered nurse, a clinician. I've had over 36 years of experience in healthcare. And in my current role with chronic disease, one of my responsibilities is to help Horizon teams and staff integrate best practices and standards for effective chronic disease prevention and management. But what I'm seeing is that these standards have not all been implemented, that there's barriers, and that we're still seeing some poor outcomes related to chronic disease. So that's why I thought I would delve into research methodology just to help try to improve those clinical outcomes related to chronic disease, use research methodology to help integrate current evidence-based practices, and I also wanted to introduce research to frontline clinical staff because in the community setting, we don't always see that research, clinical research taking place, and I wanted to expose that frontline clinical staff to research. So my first study that I'm going to review that I'm involved in is sponsored, has been accepted and sponsored by Horizons Research Services SOAR program, and it's entitled My Wellness Plan. It's a mixed methods investigation using a patient-facilitated goal-setting tool with persons living with diabetes. I am the principal investigator for this study, and the co-investigators are the Horizon SOAR team with Dr. Natasha Hansen leading that team. And why I wanted to do a study on patient-centered goals, there's a few reasons. One is that providing effective self-management support is a standard of care identified by Accreditation Canada and also by Horizon standards. We do have Horizon standards for chronic disease, and we have identified that providing that effective self-management support is essential for chronic disease prevention and management. But what's interesting, by New Brunswick Health Council data identifies that only 33% of New Brunswickers with a chronic condition feel very confident in managing their chronic condition. And only 23% of New Brunswickers indicate they usually talk to their healthcare professional about things that they could do to improve their health, such as stop smoking, drinking less alcohol, eating healthy, and exercise. And also, when I completed an environmental scan across the organization, Horizon does not have a standardized approach for patient-centered goal setting. So these were some reasons why I wanted to do some research in this. And for this project, the goal was to pilot and describe the impact of using an evidence-based structured approach in assisting patients to develop and achieve patient-centered goals. And the study took place in 5 of our diabetes education centers. Each center was located in one of our 5 different areas across Horizon. And we targeted the diabetes education centers because these teams are familiar with goal setting. So it wasn't going to be a big change in the staff's processes, just an enhancement. So just to set some context about patient goals, the literature identifies that establishing collaborative goals between the healthcare providers and the patients has many benefits. Establishing collaborative goals helps to involve the patient in their care plan and help them take ownership of their care. It also helps to increase the patient's self-efficacy and self-confidence in managing their care and chronic conditions. And it helps the patient to problem solve. And then finally, a benefit for collaborative goal setting helps to establish that trusting therapeutic relationship between the patient and the healthcare professionals. Now, the evidence demonstrates that establishing SMART goals lends to positive outcomes. And I'm sure you're all familiar with SMART goals. And so just here to highlight the different elements of a SMART goal, which we've integrated into our My Wellness plan. So a SMART goal should be specific, measurable, achievable, realistic, and timely. So our research method for the study was a concurrent nested mixed methods design, predominantly a qualitative study with supported quantitative descriptive data. And our research questions were, what were the experiences of patients with diabetes and the diabetes educators while using a structured approach to goal setting? And also, what improvements could be made to the piloted structured approach of goal setting? So our intervention for the My Wellness plan, the first 3 were just getting ready for the intervention. So the top one, to review the literature. So our Horizon SOAR research team conducted a literature review of best practices for goal setting and drafted the goal setting plan with collaboration of key stakeholders. Then we actually held focus groups with patients living with diabetes and the diabetes team just to review the draft My Wellness plan to get their input. And then we revised and edited to have our final version. And then next, we conducted staff training to the diabetes educators. We provided education session on the structured process and the guidelines of using the My Wellness plan. And then finally, the intervention, the diabetes educators implemented and used the My Wellness plan goal setting with their patients, and for the initial appointment and for follow-up appointments they had with the patient for a period of 6 months. And so the goal was for each diabetes educator to onboard at least 5 patients each. And the inclusion criteria for the patient was to be a current patient at the Diabetes Education Center, to be 19 years and older. And exclusion criteria was under 19 years of age, to be a new patient at the Diabetes Education Center. We felt that new patients, it may be overwhelming to be part of this process. Also, patients with gestational diabetes were excluded, and patients that were in the group session only at the Diabetes Center, because the My Wellness plan goal setting was intended for one-on-one interactions with the patient. So this is just to give you an idea of what our goal setting, our My Wellness plan looked like. From the best practices of the literature for setting patient-centered goals, there's several elements that should be in place to have positive outcomes. So we tried to integrate that in our 2-page My Wellness plan. So you'll see at the top is choosing a goal. So the top element was for the patient to choose their goal. And we wanted this to be a friendly looking document, so we added some pictures along with words in helping the patients decide onto what goal they would like to achieve. The next couple of sections in the document were identifying the specific goal and then actually identifying the actions for the goal, which are elements of the SMART goals. And then at the bottom is evaluating confidence. The literature identifies that for positive outcomes and goal settings, to evaluate the confidence in achieving the goal. And having a confidence of 7 or more is more likely that the goal will be achieved. If it's under 7 confidence, then the clinician would then step back and help the goal and help the patient to motivate change and do some actions for that. The second page of the My Wellness Plan, the very top, was identifying barriers and solutions for achieving the goal. In a sense, this would be the determinants of health that impact the patient. So the literature identifies there are several determinants of health or barriers that can impact goal setting. So we wanted to integrate that into our My Wellness Plan. So it wasn't just identifying the barrier, but also the solutions. So this was an opportunity for the clinician to talk with the patient and help problem solve as to what solutions could be put in place to overcome those barriers. In the center is setting a date for actions. The literature identified that by actually picking a date and writing a date down will help to take ownership and be accountable for achieving those actions to meet your goals. So we integrated that. And then finally, follow-up plan. The literature identified that having a concrete follow-up plan is essential for the success of the goal. And so identifying when, where, with whom, and how we're going to have that follow-up plan. And we offered our follow-up appointments either in person at the health center, by telephone, could be virtual video, or even email. And so our research method, we had for the project, we had onboarded 23 patients and 18 patients completed the study, and we had 5 diabetes educators onboarded and complete the study. For data collection for the patient, we obtained descriptive demographic data, as well as qualitative data was semi-structured interviews at the end of the 6-month intervention. And the diabetes educator, they collected descriptive quantitative clinical data, and for them as well was qualitative data was a semi-structured interview at the end of the intervention. So our findings, so for our descriptive quantitative data, the median age of our patient was 49. Majority of our patients were female. And for the diagnosis, we actually had 11 patients with a type 1 diabetes and 11 patients with type 2 diabetes. Majority of the patients had been living with diabetes for more than 5 years, and the majority had insulin as their primary diabetes medication management. The top 2 most common patient goals were to increase activity and to eat healthier foods. And for rating the goal, majority of the patients rated their goal as very important, and they reported high confidence of achieving their goal. And for achieving the goal, 18 patients at least partially achieved their goal. So our findings for top qualitative themes from the patient found the My Wellness Plan helpful, the goal has gone well, and they identified that they had previously set or considered their goals. And a couple of quotes from the patients were, "I think it gave me a direction. And by having a goal, I had something to aim towards." Another quote, "I was in a mindset already that I wanted to do it, and I think that helped me to achieve my goal as well." And the top qualitative themes for the diabetes educators, the My Wellness Plan is a formalized approach of what they normally do. And they liked that it was more formalized approach. And also, it was good for patients very close to action stage of change or motivated. A couple of quotes from the diabetes educators were, "I don't think it was complicated. I think it was fairly straightforward. It helps people sort out their thoughts on how to create a goal." Another quote, "I think it may be more helpful to do with the new patients who are diagnosed versus the ones who have diabetes for X amount of years." So some policy implications that we obtained from these findings were a structured approach to goal setting is helpful. To ensure the approach is easy to use for the patient and staff, not too wordy. We received some feedback and input about that. Also, training on how to develop health goals would be beneficial for some patients and the healthcare team. That had come out of the findings. And goal setting approach would be helpful for patients newly diagnosed with diabetes and or motivated to change. So what was interesting, we heard feedback that they felt that the goal setting process would be good for those newly diagnosed patients because they have many goals to achieve. So that was very interesting finding. And lastly, regular ongoing follow-up or check-ins reminders would be helpful for patients in meeting their goals. We did receive a bit of feedback that having more frequent follow-up may be appropriate. Some of the patients, it was a bit lengthy for their return appointments. They found if it was more frequent follow-up or even to use reminders or apps was suggested. So the sustainability plan for this study, first is to share results. So I've been in the process of communicating the results of the study to the Horizon Diabetes team. And then next, I'm in the process of sharing the results within the rest of the organization and externally to make adaptations. So we are going to use the feedback and the findings of this study to modify the My Wellness Plan with the goal to scale and spread this tool within Horizon staff and to external partners. The second study that I'm involved in is CAPS. It's entitled Coordinated Aging in Place Services with Integrated Primary Healthcare, a Mixed Method Study. The principal investigator is Lori Amos, the nurse manager at the health centers, Doketown and Boys Town Health Center. And I was one of the co-investigators and project coordinator for this study. This study was funded by the New Brunswick Healthy Seniors Pilot Project, along with the Public Health Agency of Canada and in-kind support from Horizon. So why we wanted to do this study in the community setting, there was a few reasons. So firstly, there is a high incidence of chronic illness within New Brunswick older adult population. About 87% of New Brunswick's older adults have at least one chronic condition, and 43% have 3 or more chronic conditions. But what's interesting, only 36% of New Brunswick older adults feel very confident in managing their chronic conditions. And this has led to a higher incidence of older adults admitted to hospital. We also wanted to reduce the risk of frailty. Frailty is a decline in cognitive and functional abilities in older adults. It is not a normal part of aging process, and we wanted to do a better job at identifying the risk of frailty. And finally, we wanted to enhance team-based primary healthcare services for older adults. Currently in our primary healthcare settings, we do not have a lot of dedicated services for older adults. So this is what we wanted to strive and enhance and evaluate. So our research goal was to pilot an innovative care pathway. We wanted to identify the impact of a nurse-led, multidisciplinary, frailty and chronic illness case management service within primary healthcare for at-risk community older adults and their caregivers. So we wanted it to be nurse-led. We wanted to enable the nurse to work to their full scope of practice in collaboration with the multidisciplinary team. And we wanted to target at-risk people in the community for frailty. But we also wanted to engage their family members or caregivers. So typically the medical appointments at the health centers don't invite the family member to be part of that medical appointment. So we wanted to engage the family member of the older adult to be part of the medical appointments in our study. So our study took place at 2 health centers in Horizon, the Central Miramichi Community Health Center in Doketown and the Boys Town Health Center. And our research method was a concurrent nested mixed methods design, predominantly qualitative with some supportive quantitative descriptive data. And our research questions were, what are the experiences of the patients, the family caregivers, and healthcare providers who participated in CAPS intervention? And how did this experience compare to their previous primary care experience? So our CAPS intervention had 5 service elements added to the intervention. So starting at the top is frailty screening. So our CAPS intervention enabled the registered nurse to work to their full scope of practice and conduct a comprehensive frailty screening assessment. And we developed an assessment tool based on current evidence-based literature and resources for frailty. And we also integrated the geriatric 5Ms into our clinical assessment. The geriatric 5Ms is a framework that identifies 5 key elements that should be addressed to produce positive outcomes in older adults. So our clinical assessments, we targeted the 5Ms. We had clinical assessments and screening for mobility, mind, being that it was cognition and depression, medication, multi-complexity, we looked at chronic illness and the determinants of health. And finally, matters most. We asked the patient, what matters most to you? And from all these assessments, then we went on to the next part of goal setting. So then the CAPS team worked collaboratively with the patient and the family member to determine patient-centered goals. Our CAPS team consisted of the registered nurse, occupational therapist, and social worker. So each of the patients, they had a frailty screening appointment with the registered nurse, and they had at least one appointment with the occupational therapist and social worker, and more so if those needs were identified. So then next was case management. So each of the patients received ongoing case management for a period of 6 months. The registered nurse acted as the case manager and was the primary clinician that had follow-up appointments with the patient. So the patient had a follow-up appointment at least monthly, if not more often, depending on their care needs. Outreach. We offered an element of outreach, and this was identified from community health needs assessments conducted in Horizon that transportation barriers were present in this community. So we wanted to offer an element of outreach. So the occupational therapist conducted a home safety assessment at each of the homes of the patients just to review safety and clinical needs that needed to be put in place. And then also for follow-up appointments, our follow-up appointment could be done in person at the health center, by telephone, if that's what the patient wished, or if the patient had barriers for transportation in coming to the health center, the CAPS team went to their home to do the follow-up appointment. And then finally, we offered consults and connections. So the CAPS team became navigators for community resources, helping the patient and family navigate those community resources. They made several consults and referrals to internal and external healthcare professionals. And also the CAPS team met with the primary provider of the patient on a monthly basis to review their care needs. So our research method, our participants, we had 3 types of participants for the study. So the older adult was the patient. We onboarded 21 and 16 completed the study. For our informal caregiver, we onboarded 10 and 9 completed the study. And we had 8 healthcare providers complete the study. And for data collection, for the participants, for the older adult and informal caregiver, we collected descriptive demographic data. For the patient, we collected descriptive quantitative clinical data as well. And then all through participants, we conducted a semi-structured interview for the qualitative data at the end of the 6-month intervention. So for our findings, for the descriptive quantitative data, majority of the patients were female. The average age of the patients were 77. For self-rated health, which we looked at the beginning and at the end of the CAPS intervention, more patients rated their health as good or excellent at the end of the CAPS intervention compared to the beginning. For clinical assessments, we had conducted these assessments at the beginning and at the end of the intervention. So these assessments for depression, orthostatic hypotension, which is a falls risk indicator, and medication adherence showed better results at the end of the CAPS intervention. And matters most, we asked the patient beginning and end, what matters most to you? And the top 3 matters most for the patient were one's health, time with family and friends, and staying in their home. But what was interesting, at the end of the intervention, another matters most surfaced, and that was to be active and mobile, which was interesting because that is a risk factor for frailty that the CAPS team were trying to really address. And so it was interesting to see that surface as a matters most. And then finally, for consults, majority of the consults and referrals were to community partners, such as non-governmental organizations and municipalities. And the municipalities in Doketown and Boys Town offered different resources for the community, such as exercise activities, the library. So those were the most of our consults were to community partners. And then second was to health professionals, such as other health professionals that were not part of the CAPS team. So the dietitian, physiotherapy, the provider. And so our top qualitative themes for our study. So for the older adult patient, the top themes were CAPS team gave me lots of information and places to get help. The CAPS program was very good and helpful. And they found the care was better with the CAPS team compared to the previous primary care experiences. One quote from a patient was, "I felt more comfortable talking to the CAPS team than I did talking to my doctor." And this may have been because we were using case management where the registered nurse was meeting with the patient every month, if not more. And that could have lent itself to establishing that trusting relationship with the patient. For the caregiver, the top qualitative themes: CAPS was excellent, CAPS provided helpful information, and they too found care was better with the CAPS team compared to the previous primary care experience. And one quote from the caregiver, "Just helping her, the patient, get some mobility and balance. She's more willing to go grocery shopping now." And then from the healthcare providers who were not part of the CAPS team, they felt patients had fantastic care with CAPS. They felt supported by the CAPS team, and they would like the CAPS program to be implemented. One quote from a healthcare provider was, "I was able to see many more patients. It was a much more better use for everybody's time, I think, and better care for the patient." And finally, the top qualitative theme for healthcare providers who were part of the CAPS team: "We felt supported together as a team, and being in a rural area makes access to services difficult." One quote from this group was, "You certainly get to see the full picture of a patient, when you're working with other disciplines." So we had seen some secondary findings as well. There were a few clinical quality improvements that we had identified throughout the study, and these were a couple that just kind of really surfaced. One was team communication and collaboration. We did see enhanced and integrated communication processes amongst the primary healthcare multidisciplinary team and external stakeholders. And so an example of this for our study, we established some processes, communication processes, just to ensure integration of the multidisciplinary team. So for example, we had established that the CAPS team would meet weekly to review the patient's care plan. So they had a weekly team huddle. And then also monthly, the CAPS team met with the provider to review the care plan. Some of the providers had not worked with the multidisciplinary team before, so this was new for them. Also, we established a process for the CAPS team to document in one central spot. So we created a multidisciplinary care plan. So this allowed the CAPS team to document their assessments and their interventions in one spot, which allowed the team to see what was being taken place within the team. And then also we created a documentation entitled a multidisciplinary team documentation tool. And in the event that the CAPS team could not meet with the provider in person, we had a process to provide the provider an update on the status of the patient. And then for external stakeholders, we had meetings with several external stakeholders just to learn what their processes are, what their referral processes were, just to strengthen that collaboration. And a second clinical quality improvement was the creative use of virtual care. So, one example was we had one patient that had to receive speech language services at the Miramichi Hospital, but this patient did not have finances to travel to the Miramichi Hospital. So, our social worker had worked with the patient to get finances, but that only lasted for a couple of appointments, and he was supposed to attend more appointments. So, what we did was we collaborated with the speech language therapy team in Miramichi Hospital, and so we piloted a staff assisted virtual appointment where one of the CAPS team attended the patient appointment. So when they accompanied the patient at their virtual appointment, so the patient came to the health center to use our video equipment, and the CAPS team was there in the room. And then when the speech therapist in Miramichi conducted their assessment with the patient, the CAPS team was present to ensure the patient was safe and was doing things properly. So it was a staff assisted appointment, and it allowed the patient to continue and complete their therapy. So, policy implications from this study are a multidisciplinary case management service for older adults within primary health care contributes to positive experiences and outcomes. Utilizing the healthcare team to their full scope of practice can be an effective use of resources. Regular, ongoing patient follow up can help to establish trusting therapeutic relationships and facilitate effective self management support for older adults. And implementing evidence based clinical practices can assist in achieving positive patient outcomes. So the sustainability plan for this project is sharing results, which we're in the process of doing. So we've done presentations at some conferences and oral presentations. We have some social media posts on Horizon social media and MEC2 website. We've created an infographic and a bilingual booklet of findings, which is targeted for the public. Both those documents are on the MEC2 website under our project, and we do plan to publish our results. We have adapted our processes. So the learnings and findings have led us to develop standardized clinical forms for Horizon Primary Healthcare Program. So we have created a staff education toolkit so that other teams across Horizon can roll out this process. We have created a frailty risk nursing assessment form for the primary healthcare program. We created a best possible medication history form for a primary healthcare program. This is an Accreditation Canada best practice on medication history, and we've created this form for the primary healthcare program to spread and scale up. And then finally, we've created a multidisciplinary care plan template from the results of our finding. And then so scale up, we do plan to spread and scale these resources across Horizon. And we've also been selected for Healthcare Excellence Canada's Strengthening Primary Care Program. And we are using this fund to sustain and evaluate the CAPS program at the Doketown Health Centre for the next 10 months with the plan to scale it up within Horizon Primary Healthcare. So my reflections in doing this research, first, as a novice researcher, I must say Horizon's research services team have been very supportive along the way. So being new to research can be a bit intimidating and scary, but the Horizon research team have made that has made it a very exciting and pleasurable experience and have helped so much along the way. Second, I want to shout out that the Horizon Research website was very helpful. It's particularly the HRPP SOP manual that's on the website. I use this a lot and I found it very resourceful. Third bullet is I did see that Horizon clinical staff were engaged with research and very interested in the findings. And that was a really nice finding to see. The clinical staff that I worked with in both of these projects had not done research before, so they were very excited to be part of a research project. They're very interested in the findings and how can we integrate the findings. So that is very promising and nice to see. Next, having patient and staff focus groups for the development of intervention processes was very informative. So, like I mentioned in the My Wellness Plan, we really wanted to have, we really want the voice of the patient and the staff in the development of our processes. So we really targeted doing that, and I found that to be very helpful. We learned a lot of tips in our processes that saved us time. One observation that we had, some of the older adults in particularly the second study, the CAP study, some of the older adults did not understand the questions in the semi-structured interview. So the research assistant had to rephrase the questions for the older adult. So it raises me to reflect, is there an opportunity to engage patients in the development of interview questions when doing a qualitative study and using semi-structured interviews? Is that an opportunity just to ensure literacy levels and health literacy understanding? And then finally, what I'm learning is integrating lessons learned from research studies takes time and work and commitment. So the sustainability piece to doing research, I'm really learning that is taking a lot of time and commitment. It's exciting to get the research findings, and we learn so much, but to really integrate them does take a lot of commitment and time. And that is it. Are there any questions?
I saw in your last reflections, you mentioned patient engagement. And as part of that, I was wondering, for both of the studies, what was the level of patient engagement in terms of recruiting people into both those studies? Because I remember from your first study, there was two arms, I believe, one where it was type 2 diabetes, the first, and then type 1, both had 11 patients each. What was the level of engagement from the patient side? Was there a lot more that you were hoping to include in the study, or was that 11 like from a group of 15? Yeah, I was wondering if you could elaborate more on that.
Mm-hmm. Well, for the first one, for the patient-centered goals and the diabetes team, we didn't have a vision of if we wanted more of the type 1 or type 2. That was just an interesting finding of who was available and was interested in the study. And as for the reach, again, we were excluding those newly diagnosed diabetes patients, which it did surface that would have been more appropriate to engage those newly diabetes patients as well. And then for the CAPS program, those older adults in primary health care, we actually used the providers. The providers at the health center were the ones that, from their rostered patients, they identified we had an eligibility criteria for those older adults, and if they met the eligibility criteria, then we approached the patient to see if they wanted to be part of the study. So for the CAPS, they had to they have to be 65 years and older, have 3 chronic conditions or one uncontrolled chronic condition or frailty score of 3 to 6. So they did have to meet that eligibility criteria, because we were looking at for people with frailty or chronic illness.
Thank you. Is there any other questions that anyone had? Oh, Jacqueline, yeah, please.
Hi there. Thanks, Paula. That was a great presentation. And it's not really a question, it's just a comment. And so as a new clinician, sort of engaging in the research process, I know you mentioned a few things that were supportive, but any feedback for us that would be helpful, because we're really trying to engage more clinicians that aren't necessarily involved in clinical trials to support their journey through the research process. So yeah, because moving more into clinical practice based on research results is where we kind of want to be. And our mantra lately is research is healthcare. So we just want to make sure that we're providing support to our clinician departments in order for them to do that. So, I'm glad to see that we were able to support you. But if you have any feedback for us, you can let us know, because we're hoping to do this quite a bit more, actually.
Okay, no, thanks, Jacqueline. I can't think of anything on the top of my head. Like the research team were very supportive. I mentioned before we started the meeting is just hearing what other research projects are going on. I know that Horizon Research Services has a website and a Skyline site, and you have a newsletter, but I'm not sure if everyone frontline sees that information, because that may stimulate interest if somehow you could just share those little pieces of information of what's going on about research in Horizon. It is hard to share all those nuggets of good information.
I just wanted to kind of comment on that, Paula. Thank you so much for your time today, and this was certainly very inspiring. I'm sure for a lot of folks who attended the session today, including myself. When you, in the very beginning, when you said you wanted to do these research because you wanted to introduce the research to the frontline clinical staff, and I thought was very inspiring that if we have people like you in Horizon, we wouldn't have no issue promoting research in our Horizon and in this province. We need more Paula in this in Horizon, right? So thank you so much for all the work that you do, and it clearly shows that the research works that we do, how little or how big it is, it just has such an impact to the care that we provide to our patients. It's amazing to see that's happening in our research community, really. Yeah, thank you.
Well, you're very welcome. And there are people very interested in research, particularly our CAPS project in primary healthcare. As you know, primary healthcare is under a bit of a limelight or microscope right now to enhance the services. So we're very fortunate to have a very interested team to participate in research. And I think, it has stimulated interest in research, and especially when they saw the positive outcomes and that we created these practical tools that we're going to spread and scale up. Now, the hard part is to sustain and scale up. I'm learning that's the hard part, especially because the teams have so much stuff going on. Right. They want to integrate it, but partnering with Healthcare Excellence Canada, that's certainly helping us. So I think just raising the awareness that research sounds scary to clinicians, but it's not that scary, because actually doing the research was easy when we had mentors like Dr. Natasha Hansen mentoring us along the way. It was easy, but now the sustainability piece is what's going to be more challenging.
Right.
It's Sarah has a question. Please go ahead and ask, Sarah.
Thanks so much. Thanks so much, Paula, for your presentation. I just like kind of a general question. So I was interested, of course, in your research very much, and the first interesting point is I'm not sure. Are you collaborating, particularly with the CAPS? Was that presented at the MBHRF conference last November? The CAPS study, was that presented there? It sounds familiar.
It was just last month at the Horizon Aging Research.
Oh, okay. I wasn't there. I thought it was maybe in November, but maybe I'm thinking.
In November, we had a poster presentation.
Oh, that's what I read it. Okay. Yeah,
Yes.
It was great to see that. Yeah, it sounded familiar. And in terms of one comment you made about the patient participants and partners enjoying the process, is a similar finding that Dr. Jarrett talks about in her dementia study. So I was just wondering if you collaborate with her, and specifically in terms of the aging in place for the CAPS, do you collaborate with Dr. Rose McCloskey as well? She's like a big guru on that topic. I was just wondering, just because I'm asking, I guess, of interest, but also in terms of research at Horizon, two things that have come out that I think New Brunswick needs to work on is not having too many pilot studies, and then them not going anywhere and not being implemented, as you mentioned. And then two, so many, it's a small province, and then if there's so many people working on the same thing, but they're individually or siloed, as the expression is, then it's kind of not working. It works against the process, right? So I was just wondering if what your thoughts are on that kind of thing.
No, thank you. Those are really good points about the collaboration with Dr. Jarrett and Dr. McCluskey. And I haven't collaborated directly with those two individuals. I know of them and know their work. I have collaborated with Carla Faig, who works, is the manager, I forget her exact role, manager for Dr. Jarrett. So her and I have collaborated and stayed connected. And I have collaborated with my study results with our Horizons Seniors Collaborative, our collaborative seniors, which is our organization for that senior centers of excellence. So I am collaborating with them. Just they're very aware of the studies. But that is a really good point about breaking down our silos in research. And I think with the CAPS project was an HSPP project, so there was a lot of funding at that time over those last couple of years for aging in place research, and we are a small province, and yes, we might have had some redundancy because we were all targeting the aging population, but now it's the big piece of sustaining those lessons learned, and I think there's been some good work in sustaining. So thank you. Those are really good points on collaborating. So I'm going to reach out.
Oh yeah, and neat. You reminded me, speaking of November, Carla Faig, I did see her presentation. It was really important, speaking of Horizon, about implementing research people like within the clinical people. I think her project was about, I think it was an oral presentation. If you know of that.
Yep.
Yeah, that was really great. Yeah, so that's neat. Were you involved in that project?
No, I
Okay.
wasn't. No.
Oh, but it complements your work, so your implementation work. Yeah, that's great. Thank you.
Thank you.
Just to, I thought I would let you know that those of you who haven't seen the chat there's message there. So just to let you know, we do have upcoming SOAR project deadline. So which is I think April 15th. So if anyone know of any clinicians or team who might be interested in applying for SOAR opportunity, please feel free to check out information in our Skyline, and also reach out and ask questions if you need any help filling out the application as well. So yeah.
Thank you again, Paula, for your excellent presentation today. And yeah, hopefully, we can have you get back here again when you're done some more work on further projects. And yeah, we can get more of a community of researchers here in New Brunswick and Horizon.
Great. Thank you very much for the opportunity.
You're welcome. All right. Thanks, everyone. Bye.
Thank you.